Hi all, this class is about anti-epileptics. We have to see definitions of two terms, seizure and epilepsy. So seizure is a single episode, a paroxysmal event due to abnormal excessive or synchronous neuronal activity in the brain. So seizure is basically a single episode of abnormal neuronal activity. And epilepsy, it's a condition in which a person has recurrent seizures due to chronic underlying process. So basically, seizure is a single episode and epilepsy is a condition of recurrent seizures. There are two main types of seizures, generalized and focal seizures. So generalized seizures include tonic-clonic seizures, absent seizures, myoclonic and atonic seizures. Focal seizures can be with or without dyscognitive features. So focal seizures were previously called as partial seizures, and focal seizures without dyscognitive features was previously classified as simple and complex partial seizures. And there is a type of focal seizure which can be secondarily generalized. So these are the main types of seizures, and you have some unknown seizure etiology also. And this is the typical picture of tonic-clonic seizures. There will be a tonic phase where all limbs and body will be in a tonic state, and then the patient goes for typical jerky movements, clonic phase, where there will be frothing and rapid jerky movements of limbs, body, and head, which is followed by a post-ictal phase of confusion, so which can last from minutes to hours. This is absent seizures, so it is most commonly seen in children. It involves sudden and brief cessation of activity with rapid return to normality, so without loss of posture or without any jerky movements of limbs. So a typical 3 Hz spike and wave pattern is seen in the EEG of patient with absent seizures. And this is myoclonic jerks or myoclonic seizures, which involves a rapid jerky movements of the limbs. The causes of epilepsy or seizures is different in children and adults. So in children, the most common causes are perinatal hypoxia and ischemia, intracranial hemorrhage and trauma, CNS infections, metabolic disturbances like hypoglycemia, hypocalcemia, hypomagnesemia, pyridoxine deficiency. It can be due to drugs withdrawal or genetic disorders, or febrile seizures, that is seizures which accompany a fever, episodes of fever. And in older adults, the most common causes are cerebrovascular disease, brain tumor, alcohol withdrawal, metabolic disorders like uremia, hepatic failure, electrolyte abnormalities, hypoglycemia or hyperglycemia, and degenerative central nervous system diseases. And these are some of the drugs which cause seizures. So asking drug history is very important because some drugs may precipitate seizures. The neurochemical basis of seizure is mainly enhanced excitatory amino acid transmission or impaired inhibitory transmission, abnormal electrical properties of the affected cells, or repeated firing of neurons which cause neuronal death, which we call it as excitotoxicity. And this is the glutamate mediated excitatory neuron, the synaptic junction. So you have to know this because here is where all the anti-seizure drugs is going to act. So you have a presynaptic nerve terminal and postsynaptic nerve or postsynaptic neuron. And in presynaptic neuron, you can see the voltage gated sodium channel. This is the voltage gated sodium channel, and this is the calcium channel, and this is the potassium channel. And you can see here, this is the synaptic vesicular protein, so which is present in the vesicular membrane. And this is the postsynaptic glutamate receptors. So this is the NMDA receptor, and this is the AMPA receptor. So you have drugs which act on this sodium channel, drugs which act on the potassium channel, calcium channel, and synaptic vesicular protein, and also you have AMPA and NMDA antagonist as well. This is the GABA mediated inhibitory neuron. So here also you can see the calcium channels and you can see the GABA transporter. Okay, so which is involved in the reuptake of the GABA neurotransmitter back into the neuron, and you have GABA transaminase enzyme, which is involved in the metabolism of GABA and again synaptic vesicular protein, and you have postsynaptic GABA receptors, GABA A and GABA B. So we have certain drugs which act on the GABA mediated GABA mediated inhibited neurons as well. And so this is the site where the sodium channel modulators act. So this is the sodium voltage gated sodium channel. So you all know the sodium channel exists in three different states: a resting state, open state, and inactivated state. So the sodium ion enter the cell only during the open state, whereas it cannot enter while the channel is in inactivated state or resting state. So here, these drugs, carbamazepine, phenytoin, topiramate, lacosamide, lamotrigine, valproate, and zonisamide, these are all the anti-seizure drugs which prolongs the inactivated state of the sodium channel, thereby decreasing the propagation of the action potential of the excitatory neurotransmitter. Excitatory neuron, and this is the T-type calcium channel, which is present mainly in the thalamus, so which is responsible for the, it acts like a pacemaker, which is responsible for the production of the 3 Hz spike wave pattern. So this is the main pathology behind the absent seizures. So you have drugs like valproate and ethosuximide, which blocks this calcium channel, T-type calcium channel in thalamus. And this is a GABA neuron. So we have vigabatrin, which inhibits this GABA transaminase enzyme, which is responsible for the metabolism of GABA. And you have valproate. It is a broad spectrum anti-seizure drug which acts at different mechanism, and one of the mechanism is inhibition of GABA transaminase. And you have a drug called as tiagabine, so which inhibits this GABA transporter, which is involved in the reuptake of GABA into the neuron. So overall, all these drugs enhances the GABAergic activity, increases the level of GABA in the synaptic junction. And also you have benzodiazepines and barbiturates, which act at the GABA receptor. So benzodiazepines basically increases the frequency of the chloride channel opening, whereas barbiturates prolongs the duration of the chloride channel opening. So now we will see individual drugs. So we will first see the important drugs which was time tested and being used for very long years, followed by newer drugs which are used as an adjuvant therapy. So the most important drug is phenytoin. So it is the most important anti-seizure drug which is used very commonly, and this acts by prolongation of the inactivated state of sodium channel. So the mechanism which we saw earlier. So it is used in generalized tonic-clonic seizures and also focal seizures. Pharmacokinetics of phenytoin is very important because the absorption is dependent on the formulation of the dosage form you are giving. So whenever you change the dosage form, so you have to be very careful because the dissolution and the absorption rate varies. And IM route is very unpredictable, so it is absorbed erratically, and hence this route is not preferred. And phenytoin is highly bound to plasma proteins, which is responsible for many drug interactions. It follows saturation kinetics, so it is eliminated by first order kinetics till a certain plasma concentration, and then it is changed to zero order kinetics once the enzymes get saturated. So the therapeutic range falls between 10 to 20 micrograms per ml. So strict therapeutic drug monitoring should be done because less than 10 micrograms has no effect, and more than 20 carries high toxicity. Drug interactions of phenytoin. So since phenytoin is a highly protein bound drug, it is displaced by drugs which are protein bound like phenylbudazones and sulfonamides when they are given together. And valproate, another anti-seizure drug, so it competes with protein binding sites of phenytoin and also inhibits the metabolism of phenytoin. So this results in elevation of free phenytoin concentration. And carbamazepine, it induces phenytoin metabolism. So these two drugs, when given together with phenytoin, has interactions. And phenytoin is metabolized by CYP2C9 and 2C90, the same enzyme which metabolizes warfarin. So when these two drugs are given together, dangerous bleeding episodes can occur because of increased warfarin concentration. And phenytoin is a potent enzyme inducer. It induces CYP3A4 enzyme. So this enzyme metabolizes oral contraceptives. So it can lead to oral contraceptive failure when given along with phenytoin. This is of particular importance because phenytoin is a teratogenic drug. So oral contraceptive failure and pregnancy can be very dangerous. Adverse effects of phenytoin can be dose related or idiosyncratic. Nystagmus is the most common first adverse effect for which dose reduction is not required, and diplopia and ataxia can occur. So these symptoms or these signs, they need dose adjustments, and sedation can occur at higher doses. Gingival hyperplasia and hirsutism can occur. This can be orism, especially when given for young ladies. And coarsening of facial features and peripheral neuropathy can occur with long-term use of phenytoin. Osteomalacia can occur because of interference with vitamin D metabolism. Megaloblastic anemia also is a dose-related adverse drug reaction. And idiosyncratic adverse reactions of phenytoin, they are very rare. It includes hypersensitivity reactions, fever, lymphadenopathy, and very rarely agranulocytosis. Phosphenytoin is a water-soluble form of phenytoin. The advantage of phosphenytoin is it can be injected with saline and glucose because phenytoin precipitates with glucose solutions. The most important adverse drug reaction of phosphenytoin is cardiac arrhythmias with or without hypotension and CNS depression. So continuous ECG monitoring is necessary when phosphenytoin is being administered, and the IV administration should not exceed 50 milligrams per minute in adults. The next important drug is carbamazepine. It causes prolongation of inactivated state of sodium channel. It is a potent enzyme inducer. It also causes autoinduction because it gets metabolized by CYP3A4. The other uses of carbamazepine, apart from epilepsy or trigeminal neuralgia, deafferentation pain, manic depressive psychosis, that is bipolar disorder, alcohol withdrawal syndrome, and diabetes insipidus, because it stimulates the secretion of antidiuretic hormone. The adverse effects of carbamazepine are again dose-related and idiosyncratic. Dose-related adverse effects are diplopia, ataxia, gastrointestinal upsets, unsteadiness, drowsiness, hyponatremia, and water intoxication. Idiosyncratic reactions are skin rashes, aplastic anemia, and agranulocytosis. There are two prodrugs, oxcarbazepine and eslicarbazepine. Oxcarbazepine is a keto analog of carbamazepine. It is a prodrug which is converted to eslicarbazepine. It is less potent enzyme inducer than carbamazepine and hence it has less drug interactions. Eslicarbazepine is again a prodrug which is converted to S-licarbazepine. It has a better safety profile and it can be given as a once daily dose. The next drug, sodium valproate, it's a broad spectrum anti-epileptic drug. It acts through different mechanisms. It causes prolongation of the sodium channels, calcium channel blockade, NMDA receptor antagonist, and it facilitates glutamic acid decarboxylase, which is involved in the synthesis of GABA, and it inhibits the GABA transaminase, which metabolizes GABA, and it inhibits histone deacetylase, and thereby modifies the gene regulation. It is used in various types of seizures like absence seizures, myoclonic, atonic, and generalized tonic-clonic seizures. The other uses of sodium valproate are bipolar disorders and in migraine prophylaxis. It's a highly ionized and highly protein bound drug, and hence it displaces phenytoin from the protein binding sites. It is an enzyme inhibitor. It inhibits CYP2C9 and 19, thereby decreasing the clearance of phenytoin and lamotrigine, which gets metabolized by the same enzymes. The most important idiosyncratic reaction of sodium valproate is the hepatotoxicity, and the other adverse effects are gastrointestinal toxicity, weight gain, hair loss. It is a teratogenic drug and it causes spina bifida and neural tube defects. Ethosuximide reduces the low threshold calcium currents, that is T-type calcium channel blocker in the thalamic neurons, and it is used only in the absent seizures. Phenobarbitone is a GABA mimetic drug. It belongs to barbiturate group of drugs. The advantages of phenobarbitone as an anti-epileptic drug are they are well tolerated. It has a long half-life and hence single dose administration is possible, and it has better patient compliance. Therapeutic drug monitoring is usually not necessary. It is very cost effective, and it is an enzyme inducer, but the most important concern with the use of phenobarbitone is it causes impairment of learning and memory in children, and hence the use is restricted in children. Benzodiazepines, they are not a choice of drug for long-term treatment of epilepsy because of tolerance, and it causes profound sedation. So, but they have very important use in status epilepticus, especially diazepam, midazolam, lorazepam. So, status epilepticus is a neurological emergency condition where there is a continuous occurrence of seizures without regain of consciousness in between. And clonazepam is used in absence myoclonic seizures and infantile spasms. Clorazepate, it is used in focal seizures as an adjuvant therapy, and clobazam is used in Lennox-Gastaut syndrome. Rectal diazepam is used for febrile seizures. So till now, we saw various conventional drugs, which were being used for so many years, and now we are going to see newer drugs which are introduced recently. They are used as monotherapy as well as an adjuvant therapy. So you have sodium channel modulator, especially the fast inactivation of the sodium channels. Lamotrigine, it delays the recovery from inactivation of sodium channels. It is a broad spectrum anti-seizure drug. It is used in Lennox-Gastaut syndrome. So this syndrome is characterized by multiple seizure types, mental retardation, and refractoriness to anti-seizure medication. So this is especially seen in children. The adverse effects are dizziness, ataxia, blurred vision, nausea, vomiting, and rashes, especially when added to other anti-seizure drugs. And Stevens-Johnson syndrome also occurs with lamotrigine. And we have drugs which causes or which enhances slow inactivation of sodium channels. So you have lacosamide. So previously this drug was thought to act through binding to a protein called as collapsed response mediator protein, which is concerned with some neurotropic growth factors and axonal differentiation and regeneration. But now this mechanism is controversial. It is used to treat focal seizures. The main adverse drug reactions are dizziness, headache, diplopia. It may contribute to suicidal ideation. So this drug carries a black box warning for this adverse effect. It has a very complete oral absorption and no known drug interactions are seen with lacosamide. Another drug, rufinamide, with the same mechanism of action, is used in Lennox-Gastaut syndrome. And you have calcium channel modulators. So two drugs, two GABA analog, gabapentin and pregabalin. So they act on the alpha 2 delta subunit of voltage gated calcium channels and decreases the release of glutamate. They actually modulate the glutamate release, and they are used in focal seizures, and they have no known drug interactions. Other uses of these drugs apart from epilepsy or migraine, deafferentation pain like post-herpetic neuralgia, diabetic neuropathy, restless leg syndrome, and also in bipolar disorders. You have GABA enhancing drugs, vigabatrin and tiagabin. So vigabatrin, as the name suggests, it is an irreversible GABA transaminase inhibitor, an enzyme which is involved in the metabolism of GABA. The most important adverse effect is progressive and permanent. There is irreversible bilateral vision loss. So for this reason, it carries a black box warning, and it is contraindicated in patients with pre-existing mental illness, and it has an orphan drug status for use in infantile spasm. Tiagabin, it inhibits the GABA transporter, which is involved in the reuptake of GABA back to the neurons. It is used as an add-on therapy for refractory focal seizures. It is contraindicated in patients with absent seizure because it can aggravate the condition by increasing the 3 Hz spike and wave pattern. Another drug, stiripentol, also enhances GABAergic transmission in the brain. It is indicated for severe myoclonic epilepsy of infancy, Dravet syndrome. It is a potent enzyme inhibitor. Then we have synaptic vesicle 2A modulators, levetiracetam and brivaracetam. They are used for focal seizures and generalized tonic-clonic seizure. So binding to this synaptic vesicle protein, it modulates the release of glutamate and GABA neurotransmitters. And it's a well-tolerated drug. It is used as an adjuvant therapy with other anti-seizure medications. And potassium channel modulator, you have ezogabine. It is otherwise called as retigabine. It is a potassium channel opener. It is used as an adjuvant therapy for focal seizure. So the adverse effects include retinal abnormalities and bluish pigmentation of skin and lips. Other serious adverse effects are QT prolongation, neuropsychiatric symptoms, including suicidal thoughts and behavioral side effects like psychosis and hallucinations. Perampanel, it is an AMPA antagonist. It causes a serious adverse behavioral reactions, including hostility, aggressions, and suicidal thoughts and behavior. It is also used as an adjuvant therapy. Felbamate is an NMDA antagonist used for focal seizure. Aplastic anemia and liver failure are the major adverse effects. And you have drugs with mixed mechanism of action. Topiramate, it reduces voltage gated sodium currents, it activates hyperpolarizing potassium current, it enhances GABA receptor currents and also limits activation of AMPA receptors. So it acts through different mechanisms. It is used in refractory focal seizures and generalized tonic-clonic seizures. Apart from epilepsy, it is also used in the management of obesity, alcohol de-addiction, and also migraine prophylaxis. The important adverse drug reactions are cognitive dysfunction, confusion, acute myopia and glaucoma, renal stones, hypospadias in male infants when exposed in utero. So these are the most important adverse effects of topiramate. Then you have zonisamide. It prolongs the inactivated state of sodium channels and also inhibits T-type calcium currents. It is also an carbonic anhydrase inhibitor. It is a sulfonamide derivative, so it causes serious skin rashes as adverse effects. That's all about the anti-seizure drugs, their mechanism of action, pharmacokinetics, and uses. Now we shall see general management of seizures. So whenever you see a person with having seizures, first immediately you have to move the person away from any danger like fire, water, machinery, or furniture. So you have to wait for the conversion to cease. Then you have to turn the patient to recovery position, which is semi-prone or left lateral position. So you have to ensure if the airway is clear, but you should not insert anything in the mouth because tongue biting occurs at the onset of the seizure and it cannot be prevented by inserting anything. And if the convulsions is continuing for more than 5 minutes or recurring without the person regaining consciousness in between, so you have to immediately call for urgent medical attention. So the patient may be drowsy or confused for 30 to 60 minutes after the seizure episode is over. So he or she should not be left alone until they get recovered completely. This is the recovery position or the semi-prone position which the patient has to be maintained during the seizure episode. So this position prevents aspiration Do we start anti-epileptic therapy for all patients after a single episode of seizure? No. So first you have to look for the etiology. So if the cause of seizure is reversible, so you have to correct the cause. So if the etiology is not reversible, or if the patient has recurrent episodes of seizure, then you have to start him or her on anti-epileptic therapy. So the aim of therapy is to achieve prolonged seizure-free periods with lowest risk of drug toxicity. The principles of anti-epileptic therapy: we have to rule out any reversible structural or metabolic abnormality, and the drug therapy should be started with a single drug and then gradually increasing the dose till you get maximum therapeutic benefit. Suppose you are going to add the second drug, before adding you have to check for patient compliance and any precipitating factors which can be treated, and fixed dose combinations are avoided because you don't know which drug cause which adverse effect. And clinical monitoring should be done, like you have to check for seizure frequency and adverse drug reactions periodically. And therapeutic drug monitoring is must for most of the drugs for dose adjustments. So when to discontinue therapy or when to stop the therapy. So you can attempt withdrawal of anti-epileptic therapy after 2 years in a patient who meets all the following criteria: complete medical control of seizures for 1 to 5 years, and if it is single seizure type, either focal or generalized, and if the patient has normal neurological examination including intelligence and normal EEG. The drug should be tapered very slowly over weeks or months, because sudden withdrawal of an anti-epileptic drug can precipitate status epilepticus. So this is the general choice of drugs which we commonly use. For generalized tonic-clonic seizure, the first line of drugs are lamotrigine and valproic acid, and the alternatives are the other drugs like zonisamide, phenytoin, carbamazepine, oxcarbazepine, topiramate, phenobarbitone, primetone, or felbamate. And for focal seizure, the first line drugs are lamotrigine, carbamazepine, oxcarbazepine, phenytoin, and levetiracetam. And for absence seizure, we have valproic acid, ethosuximide, and lamotrigine. And for atypical absence, myoclonic, and atonic seizure, the first choice of drugs are valproic acid, lamotrigine, and topiramate. Epilepsy and pregnancy. So, in pregnancy, the discontinuation of therapy carries a very high risk of status epilepticus. So, the anti-epileptic drugs should never be discontinued, citing pregnancy. So, as far as possible, pregnancy should be avoided when the patient is on anti-epileptic drugs. And every seizure episode increases birth defects in the offspring because of the anoxic episodes. So anti-epileptic drugs should be continued, and prophylactic folic acid supplementation should be given in the all the trimesters, and vitamin K supplementation should be given in the last month of pregnancy. Febrile seizure, it is seen under 5 years of age. So they develop seizure episodes during fever. You have to treat it with paracetamol and external cooling. You should bring down the temperature quickly. Rectal diazepam, 0.5 milligram per kg, can be given at the onset of convulsion, and the drug is repeated 12 hourly for 4 doses can be given. Intermittent prophylaxis with diazepam at the onset of fever is also advocated. Status epilepticus is a neurological emergency. So we call it status epilepticus when the seizure activity occurs for more than 30 minutes or two or more seizure occurring without recovery of consciousness. So the general measures are maintenance of patent airway, oxygenation, fluid electrolyte balance, maintenance of blood pressure, normal cardiac rhythm, and euglycemia. These are the drugs which are used in status epilepticus. So first you have to give lorazepam 4 milligrams IV at the rate of 2 milligrams per minute, repeated once after 10 minutes if required. So lorazepam is preferred over diazepam because of the lower lipid solubility and slow redistribution. Suppose if the seizure is not controlled with lorazepam, then you can add phenytoin 100 to 150 milligrams per minute slow IV infusion under continuous ECG monitoring. And still, if the seizure is not controlled, then you can give Phenobarbitone 50 to 100 milligrams per minute IV. In refractory cases, so if the status is not controlled by all the above drugs, then you can go for IV midazolam, propofol, thiopentone anesthesia with or without curization. So this is the last result. So that's all about management of epilepsy, various types, the status epilepticus, and epilepsy in pregnancy. So all we have seen. So we celebrate 17th November as National Epilepsy Day. Thank you.